Well, good morning. Welcome to Key Island. It's a little rainy today, but the sun's going to shine. You're going to have a great time on the beach. I'm Dr. Veronica Pijak, and I want to welcome you. This is about our 28th, I don't know, conference.
Close,
okay.
close
Here
enough.
at Kiowa, and I've lost track of time here. But I want to also thank Randy Glick, who puts this together and really helps us out. And Lee is in the back. If you have any problems, she can help you problems with your housing, problems with where to go. Now she's an expert on Kiowa too. We're having a webcast today, and so there are other people joining us, and they're going to be in the ether. So be sure you send us your evaluations. We really do listen to what you want to hear, and we would love to have you tell us about the conference, what you think about it, what you think about our speakers, and what you think about you want to hear for next year. In addition to that, I want to introduce my co-chairs, Don DePetty, who seems to have flitted out of the room. Oh, there he is in the back, very good. And Joan Lingen. And Joan's going to talk to us first today about mammogram screening guidelines. So again, if we're all here, if you have any questions or any problems, let us know. We'll be happy to help you.
Good morning, everyone. Thank you for getting up bright and early. And we're going to delve right into what is, to some degree, is actually going to be controversies in mammogram screening and in breast screening in general. Some references for you. There are some additional references that will come up as we go through the talk as well. I'm actually from the Eastern Shore of Virginia. When I tell people that, I often get kind of a blank stare, so I feel a little bit obligated to give a little background on that as well. The Eastern Shore is actually a peninsula that is on the east coast of both Virginia and Maryland. It's referred to as the Delmarva Peninsula because it's actually made up of parts of Delaware, Maryland, and Virginia. The peninsula at the bottom is the 70-mile stretch that is the eastern shore of Virginia. It's connected to Norfolk, Virginia Beach by the Chesapeake Bay Bridge Tunnel, which is a 20-mile bridge tunnel complex that when you're actually out in the middle of, you've got the Chesapeake Bay on one side and the Atlantic Ocean on the other. It's actually a pretty amazing drive. Towards the top of the eastern shore of Virginia, you can see some barrier islands. And some of you may be familiar with Chincoteague ponies, made famous by Marguerite Henry's book, Misty of Chincoteague. More recently, the area is known for the NASA Wallops Complex, which has been shooting rockets, and this is one of them. I'm actually the clinical director of the Franktown Community Health Center, which is about an hour's drive south of Chincoteague. It's one of 5 federally qualified health centers that make up Eastern Shore Rural Health and provide care to the residents of the Eastern Shore. So some background regarding breast cancer. The current estimate is about a 12% lifetime risk for women to develop breast cancer, or about 1 in 8. Breast cancer does remain the second leading cause of cancer death in women in the United States. Approximately 40,000 women will die from breast cancer each year. And obviously the goal of mammography is to detect breast cancer early in order to reduce mortality. So the previous guidelines, the ones we all knew and loved, and at least the ones I initially trained with, were a baseline mammogram at 35, which kind of morphed into 40 more recently. Repeat that every year. And there really was never a definite stopping age. It was basically once the patient didn't want to go, or when you had the discussion about, well, what if there's a positive finding? Are you willing to have additional studies or biopsies? Once that answer was no, then there probably wasn't much point in continuing to screen. So there have been a lot of changes recently, and what prompted those changes was the goal of decreasing unnecessary testing for benign conditions. Again, those additional spot compressions, ultrasounds, biopsies, which, as we know, create a lot of emotional strife for patients, and often would come back negative. and sometimes would then deter them from doing screening in the future. Risk-benefit analysis, and the fact that approximately 50% of those who have an annual mammogram every year for 10 years will have a false positive, and then up to 20% of those are going to wind up being biopsied. So we're going to review the various organizations' guidelines as they currently stand for screening mammograms. So the American College of OBGYN had stated baseline mammogram is 40, repeat annually, and consider discontinuing at age 75. And this was the August 2011 practice bulletin. But wait, I literally submitted these slides on June 1st, and as I was driving to work on June 22nd, we had the NPR moment where I hear newsflash, ACOG has revised the breast cancer screening guidelines. And indeed, when I got to work and opened my computer, I found that the press release stated that for women of average risk, they should be offered, and that was emphasized, offered a baseline mammogram starting at age 40 and no later than age 50, with the emphasis being on shared decision making. Also, the emphasis was on discussing both the potential benefits and the potential harms regarding mammograms. Further screening should be done every 1 to 2 years, again, based on an informed, shared decision-making process that includes discussion of benefits and harms of annual versus biennial screening and incorporates the patient's values and preferences. So really, more than anything, a change in tone. At the age to quit became at least 75 years old, and beyond that, again, shared decision making based on the woman's health status and longevity to whatever degree that can be projected. And these guidelines have been incorporated in the newest ACOG guideline, which was just released this month. So that's bulletin number 179. July 7, 2017, breast cancer risk assessment and screening in average risk women. So then we come to the U.S. Preventative Services Task Force. Their recommendations are a baseline screening mammogram at age 50, but should be individualized. Repeat every 2 years between ages 50 and 74. And they feel that there is insufficient evidence to recommend screening in women over age 75 or older. The National Cancer Institute has the easiest guidelines. Baseline at 40, repeat every 1 to 2 years. The American Cancer Society throws a real monkey wrench in trying to figure out how to deal with this. They recommend a baseline screening mammogram at age 45 for most, but there should be the opportunity to begin screening annually between the ages of 40 and 44. They recommend annual screening 45 to 54, but at age 55 and older, begin transitioning to biennial, but still have the opportunity to screen annually should the clinician and patient so desire. They recommend continuing to screen as long as overall health is good and there's a life expectancy of 10 years or more. Breast exams. So who would have expected this to be controversial, but yet it has become. So both ACOG and the American Cancer Society say clinical breast exam every 1 to 3 years in those under 40, 20 to 39, and then annually after age 40. Again, a change in tone. The recommendation is now breast self-awareness versus exam. Encouraging women to be aware of what their normal breast architecture feels like, as opposed to emphasizing any specific method of exam, which often deters patients. And I'm sure you often hear, well, I don't do it because I'm not sure how to do it correctly. So moving away from what's correct to just an awareness of one's own breasts. The National Cancer Institute recommends clinical breast exams, but does not recommend breast self-exam or breast self-exam instruction. The U.S. Preventative Services Task Force feels that there is insufficient evidence to support performing clinical breast exams at all, and does not recommend self-breast exams. And then there's breast MRI, which is another controversial topic. So ACOG does not recommend the use of MRI or other alternate screenings for dense breasts in patients who are asymptomatic and have no additional risk factors. The American Cancer Society recommends the use of MRI with mammogram in those that are high risk, which they define as a 20 to 25% lifetime risk starting age 30, and we're going to look at some of the ways that risk is calculated. So the slide's a little bit busy, but basically the first group are those that are considered high risk, 20 to 25%. So those with a BRCA1 gene or gene mutation, those who have a first-degree relative with those mutations, those who had radiation therapy to their chest between the ages of 10 and 30, those with syndromes that increase their risk of breast cancer, as opposed to the moderately increased risk, those are the 15 to 20% lifetime risk. So some of that is based on family history, personal history of breast cancer, ductal carcinoma, lobular carcinoma, atypical hyperplasia, or atypical lobular hyperplasia. And then there's the issue of extremely dense breasts or unevenly dense breasts. So the benefits of mammography, again, the idea being what we're trying to do ultimately is prevent death from breast cancer. So for 10,000 women of average risk who have mammograms for the next 10 years, what you see is an increasing benefit with increasing age. So 5 deaths prevented in those ages 40 to 49, 10 in those age 50 to 59, but 42 in those age 60 to 69, which again sort of explains the shift we're seeing. However, if the individual risk is higher than average, then obviously the benefit may also be higher. Harms, well, the big one is false positive results. The risk is actually higher when that baseline mammogram is done at an earlier age or when they are done annually. Again, showing why we've got some of the changes in recommendations. And then there's the risk of overdiagnosing. So diagnosing non-clinically significant tumors or tumors in patients that have competing comorbidity and age that would be priority. So how do you estimate the individual women's risk of breast cancer? So the first is there is an online tool, and the website is www.cancer.gov, BC Risk Tool, that you can pull up on your computer, and it lists a series of questions that allows you to calculate both a 5-year and lifetime risk. There's also a phone app based on the Gale model. That's actually a free download. And I'll put in a plug for Thursday. We're actually going to do an entire session on different phone apps that you can use to in your clinical practice. So this is a screenshot of the website-based risk assessment tool that can be done either by the patient individually or in the office. And the patient basically goes through and answers the questions. And these are screenshots of the phone app. The first screen is where the questions are answered. The second one calculates the risk. Again, it calculates the 5-year risk for that particular patient versus an average woman of that age, and then a lifetime risk. So then the question of where do the insurers stand? Well, the Affordable Care Act actually requires insurers to cover mammograms every 1 to 2 years, starting at age 40 without the need for copay. Medicare Part B covers one baseline mammogram between ages 35 and 39, and then a screening mammogram every 12 months at no cost, providing the healthcare provider accepts assignment. Medicaid benefits vary greatly, and the Kaiser Foundation does have a table that will allow you to look up your individual state, and that's the reference for that. Accreditation organizations also vary. So HRSA, the Health Resources and Services Administration, cites the American Cancer Association guidelines. For those of us that are involved with patient-centered medical home, NCQA, those measures include the number of patients aged 40 to 69 who've had a mammogram in the past year. So when you get those reports, they're going to rate you based on how many of your patients have had an annual mammogram, despite some of what we've already discussed. For those of us that are working in SCHQs, you're well familiar with federal uniform data sets, which are some of the things that we're graded by. They actually require tracking the number of women over age 50 who have not had a mammogram in the last 2 years. So then the question becomes, what do you tell your patients? Well, the most honest thing is to admit that there are conflicting guidelines regarding what age you should start and how frequently you should have a mammogram. The recommendation is that you review the patient's breast cancer risk factors and discuss whether she's considered to be average or above average risk. Discuss the possibility of the need for additional views, biopsies, additional treatment, so that that's not a big shock if that becomes the situation. And then the challenge is to document the results of this discussion in your office note, all of which, of course, is going to be done in your 15-minute visit. Actually, along those lines, for those of you working with electronic medical records and templates, one possibility there is to actually create a template that would drop down a lot of the guidance about mammograms, and that you have discussed that. Of course, the caveat being that once you drop that template down that says you've discussed those things, one has to be sure that one actually has done that. Okay, so now we're going to move to our audience participation. And this is if you've got your smartphone, this is where the questions are going to be listed. So the first question was, which of the following is true? A, there is general consensus that baseline mammograms should be done at 40. B, there is general consensus that mammograms should be done annually after age 50. C, there is general consensus that women over 40 should have clinical breast exams. Or D, Medicare will pay for an annual mammogram in women aged 40 to 65 who are at average risk for breast cancer. Obviously, those that are Medicare eligible. And actually, the answer is D. There is, at the moment, there is not, the Medicare will pay for annual mammograms. Question 2, ACOG guidelines recommend all the following except A, a baseline mammogram at age 40, B, breast MRI if reported to have extremely dense breasts, C, breast self-exam, or breast self-awareness is encouraged, or D, discussing discontinuing screening with patients at age 75. And the answer is ACOG does not recommend the use of breast MRI. Third question, the American Cancer Society guidelines recommend A, a baseline mammogram at age 45, annual screening from ages 45 to 54, or biennial screening from age 55 until life expectancy of at least 10 years, and the answer is all the above. Question 4, the U.S. Preventative Services Task Force recommends all the following except biennial screening for women aged 50 to 74, continuing mammograms after age 75 for those with a life expectancy of at least 10 years. They conclude that the benefit of screening for those 40 to 49 while positive is still small. The decision to start screening mammograms prior to age 50 should be an individual one. And the answer is that the U.S. Preventative Services Task Force does not find any benefit in continuing mammograms after age 75. So B is false. B is the correct answer. And last but not least, A screening test that detects small tumors that are unlikely to become clinically evident is referred to as A, a highly sensitive screening test, B, a highly specific screening test, C, overdiagnosis, or D, an underpowered screening test. And the answer is that it is overdiagnosis. There we go. Any questions? And you had one from the web?
Yeah.
Time out for technical difficulties. So our web participants have sent in some questions. One is, what are 3D mammograms? So in a 3D mammogram, they actually repetitively move the X-ray arm and take multiple images and are therefore able to construct a 3D image. Again, not something ACOG is currently recommending. And then the next question was, do you frequently send women to genetics counselors with a positive history of family breast cancer? It's certainly ideal. Unfortunately, in my particular case, I do not have a genetic counselor. Probably the closest one is going to be about 60 miles from my location, so that does not happen very frequently. But if you have that available, certainly that would be ideal.
I do not. I'm an endocrinologist, so I don't.
Yes, you got it.
I'm an endocrinologist, so I don't routinely order a lot of mammograms, but just wanted to get your take on what the current risk factors are beyond family history and the BCRA mutations and so forth.
Well, we just, some of them listed, radiation exposure at a young age. There are some syndromes that increase one's risk. History of, personal history of atypia on biopsies.
Can you comment a little bit more on breast density? In the state of New Jersey, we are obligated to tell our patients when it's at least over 25 to 50% dense, and then we have to send them for bilateral ultrasounds, and then sometimes MRIs on top of that. And how often would you suggest we do the ultrasounds? Because every year it's still going to be dense. It's not going to change probably for a good number of years. Thank you.
Yeah, New Jersey is definitely has very strict guidelines, and the only thing I can recommend is that you follow. Actually, the New Jersey's section of the American College of OB/GYN has a whole webpage about that with their recommendations, and I would follow your state guidelines. I don't practice in a state that has those, but I would follow what their recommendations are.
I have patients who have arrived at the mammography suite and have been asked if they want a 3D mammogram. How would you advise on that?
So in most places, as far as I've learned, that's generally not covered by their insurance, and they're generally asked to hand over someplace between $50 and $100. And from what I've heard from most patients, the inclination is that, well, it's being recommended, so I should do it. And I usually hear about it afterwards, and my answer usually is that I actually would not recommend it. Again, in an average risk woman, there isn't really good evidence to show that that's going to improve our ability to detect early breast cancer. Another question from the webcast. How do you handle patient reminders for patients who have not had a screening mammogram as encouraged to appointment? So in my particular system, we use the eClinicalWorks EHR, which has various reminders built in. And so in my chart, it actually is going to sort of flash at me if there's an open referral. And so we would bring up that, you had an appointment on April 15th, 2017. We didn't get a report. Did you go? Oftentimes the answer is I forgot. And then what we do is document in the chart that the patient was reminded to reschedule. And then we actually continue to do that until we can close that referral. So as long as that referral is open, it tweaks us to remind us that we need to continue to bring that subject up at subsequent visits.